each year it's held in 16th November to increase the awareness of COPD. We'll start with the case scenario. Double click the make it. Oh, cool. Right. So we got a 70-year-old man admitted to. So this is the slide before. I want the slide before. First slide. Echo. Alright, that one. Right, okay. So this patient was admitted with to the medical casualty. Then he gave a history of dyspnea of 2 weeks, and he had cough intermittent, and he gives a past history. He said that he had been having central chest pain on and off, and back pain, significant back pain, and drugs. He says that he has been taking inhalers intermittently. Whenever he wanted to take, whenever he felt breathless, he took the inhalers, and he has been a smoker, 10 VD per day for the past about 40 years. Right. How do I click? Make a left click. This one. This one to go forward. Yes. I'll click here. Oi. So on examination, this patient was dyspneic, and he had a pulse rate of 110, blood pressure was normal. He had a high tachypneic, the temperature was normal. This patient was very thin, had a BMI below 17, and the positive findings on systematic examination was that he has a cardiovascular, he had a parasternal lift, and he had a loud P2, suggestive of pulmonary hypertension, and chest was barrel shaped, and on auscultation he had widespread bronchi and crepitations. So investigations showed the ECG, there was old inflammation, blood gases show oxygen of 65, he was very hypoxic, and carbon dioxide was 67. He was having severe hypercapnia, and the pH show his acidotic. Acidotic with pH of 7.2 and bicarb was high. So all this summarizes into a acute and chronic respiratory failure, hypercapnic. Now this is his chest X-ray. Now you see this patient has large volume lungs. Up to his 11th rib was exposed, 12th rib was just visible. So it has a huge amount of air trapping, and you see air is seeping under the heart, under the diaphragm, again suggest of air trapping, and then large barrel shaped chest, and you see the pulmonary artery is about more than 12 millimeters. So he has evidence of pulmonary hypertension. So with this history of severe dyspnea with respiratory failure, diagnosis of acute exacerbation of COPD was made. He was initiated on oxygen therapy, nebulization, and sorry about this, antibiotics and systemic steroids, and he was started on NIV, but the same night he died. So that now the 70-year-old carpenter, should he die? Where have we gone wrong? So what more can we do to save this kind of lives? So this is, we are going to learn that in a very, very short nutshell, in a summarized form today. Now this is the theme of the World COPD Day this year, your lungs for life. So they are elaborating more on lung health from the birth, and then to be keeping good lungs. but I think we are far behind them. We are million years behind this team when it comes to COPD, and you know, all of you know why. Now, we'll know the disease. It's a preventable and treatable disease, and it is actually it is a disease which would have prevented. Now, this Somapalas disease would have prevented about 50 years ago, and then it was treated much better than this. And he had significant extrapulmonary effects. He has osteoporosis, the back pain was due to that. Nobody has addressed that. And he has ischemic heart disease. This in fact has gone unnoticed. The chest tightness, chest pain, maybe that also would have managed as acute exacerbation of COPD. And this is also very important to consider when COPD is a disease where their comorbidities are very much common and then very much had to be taken into account. And this was stressed about 2 years ago in a World COPD Day. And this pulmonary component is the basic thing is that airflow limitation, which is not fully reversible. It is reversible. That's why we give bronchodilators, but it's not fully reversible as much as in asthma. There is some permanent significant change, and then they have added 2 years ago alveolar changes. There are alveolar changes, not only the airway, because the destruction of the alveoli would lead to again that will contribute to the significant hypoxia. And the disease is progressive irrespective of you stop smoking. It is enhanced inflammation, so even you stop smoking, you stop all the exposures, the disease will progress. And then it is abnormal inflammation. That is why it is called abnormal, because injurious agent taken away. But once it's set in, there's no comeback. It will lead to death. And it is the third common cause of death now in the world. It is a deadly disease to have. And it is caused by inhalation of noxious gas can particles. Now, this slide, this beautiful slide, summarizes COPD, the slide by Dr. Koslow. This is a normal bronchiole. You see this bronchiole has very thin wall, and you know respiratory bronchioles and beyond, they will take part even in air exchange. And then these are the alveolar walls. You see how thin they are, and the alveolar walls are kept open by these alveolar attachments. Now, when in chronic obstructive, in chronic bronchitis, this you see how thick the wall due to inflammation and how narrow the lumen is. And more in emphysema, you get pathological destruction of the airway, and therefore all these alveolar attachments are lost, and the airway will collapse prematurely. When the patient is trying to breathe out, this has collapsed, and there will be a lot of air trapping, and it's very difficult for these people to breathe on top of increased residual volume. It's like that you take a deep breath in, hold and try to breathe on top of that and try to exercise. So that's difficult for COPD patients to breathe. So this is in a nutshell. These two slides will tell you more than many words about COPD is, and they have significant comorbidities, not only COPD. So please think of infarcts, osteoporosis, infections are very common, and they are having depression. It's a very common scenario that these people get depressed due to the chronic disabilities and many other reasons. And then diabetes, they are more prone to diabetes, and of course COPD, they are the common risk factors being lung cancer. And we have the disease called ACO. This is asthma and COPD overlap syndrome. Again, it is not a new entity, but then we have to consider that also in great detail. When a COPD patient comes, you have to think whether there is any component of asthma there. Right. So, and it's not only a pulmonary disease. The inflammation is spillover, and you get it's a systemic inflammatory disorder where there is lots of sarcopenia, weight loss, and nutritional abnormalities, and it's a disease which is leading to skeletal muscle dysfunction. This inflammation is not only confined to the lung, but it is causing the rest of the system to inflame. Right. Now, how to diagnose? It's a clinical diagnosis. If a person has cough with sputum production and dyspnea, progressive dyspnea with cough, And if you have the patient gives a history of exposure to tobacco, smoke, occupational exposures, indoor and outdoor air pollution, then you think of COPD. And the slide from the global COPD arena, that is the GOLD, that's Global Initiative of Obstructive Lung Disease, would advise us to do spirometry. But in Sri Lanka, this scenario is quite different. I'll tell you why. And why, the next slides will tell us what the use of spirometry in our scenario at the current situation. Right. Now this is, can't I go like this? Right, I'll do this, right? Okay, now you know the normal spirometry, the flow volume loop, and then you see here is you have the flow volume time curve. Now this is the time and this is the volume, and then in the first second, FEV1, you breathe out about 70 to 80% of your post expiratory volume. And then in COPD, in obstructive airway disease, including asthma, you will have you will have the FEV1 reduced, so that FEV1 FVC ratio post bronchodilator, it has to be done. Pre-bronchodilator, post-bronchodilator is very important, especially the MDs. Without this answer, you will fail the MD exam. How are you going to confirm the diagnosis? You have to do post-bronchodilator FEV1 FVC ratio, because if you do pre-bronchodilator, FEV1 FVC ratio can be low in asthma also. But if it's responding to, if it responds to bronchodilators and if it is becoming less than 70, it is asthma. So therefore, you treat as asthma. And asthma is a very rewarding disease to treat, and then it's a very dangerous disease if you don't treat well. Asthma can kill, and it is unlike COPD. This asthma deaths can be prevented very much, but not the COPD deaths very much. So that is post-bronchodilator FEV1 FVC ratio less than 70, diagnosis COPD. And then once you have the FEV1 value figure, then you can use that figure to classify the severity. If we do remember only three digits, 80, 30 and 50. If it is less than 30, it is very severe COPD. 30 of the predicted value. You take the predicted value of a person of the same age, height, sex and race, the FEV1 value, and then express as a percentage of that value. So if it is less than 30% of a normal person, it is very severe COPD. Between 50 to 30, it is severe. Between 50 to 80, it is moderate, and then above 100 to 80, it will be 100 to 80, it will be mild. So this is how you classify airflow limitation in spirometry. And then you have now this only says about airflow limitation. But what about the clinical disability? So therefore, this was prevailing for the classification of severity of COPD nearly up to about 2015. The gold, these slides, they began dispensing this and giving all the heavy evidence-based science from 1998. But in 2015, they changed this, and then they went into this, the ABCD of COPD. Now, this ABCD again, first it was depending on the FEV1 FVC ratio, but now it is just pure clinical science. At any peripheral unit or any rural hospital, you can classify this into ABCD. And then now this is the A people who are in this line, onto the left on this line, A and C, are people who are having MRC dyspnea scale of less than 2. Now MRC dyspnea scale is a very good way of assessing dyspnea. All the medical students know that it is very easy to, I will come back to that. The dyspnea scale is there, but everybody knows that it is like NYHA mild dyspnea. So it is a dyspnea scale of less than 1, less than 2. 2 or more will go to B and D, and A and B will go to COD, depending on how many times you got worse last year during the past 12 months. If you had at least one hospital admission, you go into climb on to COD. And then if you had two exacerbation without even hospital admissions, again you go there. So it's a disease where the severity is very much dependent on the amount of exacerbation, and people who have done medicine, you will know how much time you spent on the casualty nights on managing these COPDs. Now, people who are having D are the people who we see, unfortunately. So that when a person is having recurrent admissions and who has a dyspnea scale of more than 2, I don't think there is any place for spirometry unless you are enrolling them in some research, because you don't have to do spirometry to diagnose them. It's a very clinical diagnosis. So why does this world body says to do tell us to do spirometry? It is to diagnose people in stage A. Now this Mr. Sompalu who died would have gone into stage A somewhere around 40 years, from the age of 40. Now he was 70 years when he died. So at that time, if somebody, but at that time, you would have been not having symptoms, very mild symptoms on exertion. But if we had done this at that time, we would have showed him this figure and then put him on treatment. Treatment is not that all that marvelous, but it's good. It's a treatable disease. It's a preventable disease, and it is pharmacological and non-pharmacological. And Dr. Ratanayak will do a great deal on pharmacology management. But it would have this death would have prevented, and then this disability would have been prevented. Then the patient would have had enjoyed a very good quality of life without being unable to move out of house. Now that is the MRC dyspnea scale 4, right? Right, now you can download this from any website, any website of medicine. It is similar to NYHA, but we have the MRC 0. Grade 0 is that for normal people. Right, so this is this MRC dyspnea scale is the best way to put the patient on from people to A and B or C or D, and then a history of exacerbations. We put them from A and B to C and D. Simple as that. But at the same time, if you have spirometry, you can put them according to the gold stage, mild, severe, that stage, depending on 30, 60 and 80, 30, 50 and 80. Right, now how do you manage? You have to assess and monitor the disease, and then reduce the risk factors. Cessation of smoking and proportional exposures are very important. And then to manage stable COPD, and then what to do when they come to the hospital. Right, now pharmacological therapy will be dealt with Dr. Ratanayak, and then there are the non-pharmacological measures which is very important, is that smoke cessation is very important. It is not just asking how much you smoke, also it will be helpful, but then you have to get them into a good program to monitor them. And then pulmonary rehabilitation is very important for them to get them to do aerobic exercise, and then to improve their respiratory muscle strength. And nutrition is an extremely important aspect because of the things that we have, because there's spillover of inflammation. It is going to be directly hitting the striated muscle and keeping people very poor functional status. And then vaccination, very important. Now we know it is a must to give all the COPD patients pneumococcal vaccination and influenza vaccination yearly, and the COVID vaccination. In some countries they will reinforce with the pertussis vaccination also. So it is very cost effective rather than packing them with merpanam and then tests when they come to the hospital. It prevents this. A cheap vaccine with say 13-valent polysaccharide vaccine is, if it is there, it's good, but now this vaccine is not available. Not, it has been there, but not in the government sector, no in the private sector. Then home oxygen when they are going to respiratory failure, home NIV when there's type 1, get home oxygen. When you go into type 2, that is hypercapnia, home NIV can be considered. All that will keep people away from hospital, and then will save lots of money to their families and to the country. And then LVRS, that is lung volume reduction surgery. It is being done in a great way in the rich countries where there are emphysematous bullae. The commonest thing which can be done will be wax bullectomies, stapling of the bulla, or you may do endobronchial lung volume reduction. It is also a very sort of easy technique if you have the correct equipment, so that you can block the bronchotransmitter segment which has large emphysematous bulla, so that the rest of the lung will expand. And then, since it is a very common cause of death, the third common cause of death, you may have to take end of life decisions. And in units where I trained, they are not to be intubated. Those countries, even the rich countries, they gave NIV, but they take the decision not to intubate because they will have a protracted suffering on the ventilator, block the ventilator for many months or sometimes months, and then they die. Even if you wean them off, the next week they will come back with to be ventilated. So all in all, what I say is, my message is, diagnose COPD early. It is a treatable and preventable disease, not when it is stage D. When not it is in copulmonale. At that time, the patients will not want to go on treatment. You have to show these spirometric figures to convince them for treatment. So I thank you for your attendance, and then I hand over to Dr. Prabhudatta Nayaka to see how we can treat them with drugs.